This is the third of 4 videos covering positioning of the cranial vault. In this video we'll be looking at the facial bones. Prior to watching this video, please ensure that you have had a look at the videos covering the cranial vault and also the paranasal sinuses. When first learning positioning of the facial bones, it's important to understand a couple of background concepts. The first of which being that the facial bones are very fine structures. There are particular structures of the facial bones which are very, very thin, quite difficult to see, and when they do fracture, some of the fracture structures are quite fine. As a result of this and the fact that the facial bones often have superimposition of adjacent structures, CT is an excellent modality for being able to investigate facial bones injuries. One of the advantages of plane rays, however, apart from the fact that it can have a very, very much lower dose than a CT scan, is the fact that plane radiography can show signs of a fracture. And the most notable of these is fluid levels within and around the maxillary sinuses. For each of the images of the facial bones, we're going to be using a 24x30 image receptor. The central row will be in the middle of that image receptor in each time, and the image receptor is going to cover the entirety of the facial bones. We'll be using a portrait orientation in all cases. In front of you there, you can see that I've listed the standard views of the facial bones, indicating a couple of Waters projections and a lateral. I would like for you to understand that this is an incredibly variable quantity, and that depending upon the needs or desires of the radiologist, maxillofacial surgeon, ENT surgeon and so forth, these things may change, and in fact are very, very likely to change. So please do recognize that this is quite a variable body region. It is going to change depending upon where you find yourself on placement or working in the professional environment. Positioning for the Waters projection is covered in the previous video where we had a look at the radiography of the paranasal sinuses. Please note that when you do have a look at your textbooks with regard to the Waters projection, it will indicate that the positioning is a 37-degree angulation of the orbitomeatal line. I'd like for you to be aware that that 37-degree angle is actually from the vertical axis as opposed to the horizontal axis. As you can see here, for a well-positioned Waters projection, the orbitomeatal line is 37 degrees from vertical or 53 degrees from horizontal. Please make sure you are clear on that. In the previous video, we talked about how you can adapt from a standard chin and nose in touch with the image receptor, and then to extend the neck further depending upon the facial-maxillary structure and profile of the patient to be able to get that 53 degrees. This photograph shows a patient in a Waters projection, and you can see that this is a young patient who's very likely to be able to move quite freely, and yet it's still quite an uncomfortable position. You can see that the neck has been extended quite a long way. Now, one of the things about the Waters projection is that when you are performing this series, you need to take multiple Waters projections with the patient in the same position. One of the things which I would advocate, therefore, is to communicate with your patient, let them know that you're going to put them into a particular position and that you would like for them to stay in that position whilst you perform 1, 2, 3 images in a row. The tube angulation is going to be the only factor that changes and correspondingly the image receptor, but otherwise the patient position stays the same. So you are essentially going to be convincing the patient to stay in an uncomfortable position for a couple of minutes. The positioning of a patient for a Waters projection with a zero angulation, or the Waters zero as it is commonly known, is exactly the same as described in the sinus video previously available to you. The criteria once again match that. The infraorbital margin should be a horizontal and thin structure. The entirety of the facial structures should be visualized, so you should see everything from the top of the orbits down to essentially the bottom of the ethmoid and sphenoidal sinuses should be shown. If you don't show the entirety of the mandible, that is acceptable because the mandible is a structure which needs to be visualized as a separate entity. There should be no excessive tilt of the head as shown by that inferior orbital margin being shown in as a flat profiled structure, and there should be no rotation as evidenced by symmetry of bilateral structures. The maxillary sinus, those approximately triangular structures that you can see underneath the patient's orbits, should be shown fairly maximally. It's quite common, however, for the bony structures behind it to be visualized over the bottom third of the maxillary sinus. We will move on now to the Waters 20, or also known as the extended Waters projection. The Waters projection has the patient positioned identically to the Waters 0 or zero angulation projection. There are two differences. The first difference is that there is a 20-degree chordad angulation of the tube. Correspondingly, because structures will be projected further inferiorly, we need to move the image receptor inferiorly to correspond to that. Otherwise, the projection, in all ways, is similar to the Waters 0 projection. It's important to note that this projection has a 20-degree chordad angulation, but depending upon where you find yourself working, it might be advocated that a 15-degree Waters projection is utilized. Indeed, there will be some imaging centers where it may be the routine projections to perform a Waters 0, 15 down and 30 down, or 20 down and 40 down. This is something which is very subjective and is normally considered and negotiated between the maxillofacial team and the radiology team. Otherwise, positioning, projection, and collimation is exactly as before. You can see in this projection, this photograph, that the patient is once again in an identical position, and in this situation we would once again be saying to the patient we're going to be taking 2 or maybe 3 projections. Try to stay in that position while we continue to perform these projections, and I'll get you to relax at the end of the series. When this projection has been performed, well, it should have slightly different criteria to the previous. The inferior orbital margin won't be completely flat now. It will be a relatively thin structure. The previous criteria with regard to rotation or tilt are entirely the same. However, the maxillary antrum, that is to say that the entirety of the maxillary sinus, including the inferior most point, should be shown maximally. In this image, if you have a look at the inferior part of the patient's maxillary sinus, you should be able to see virtually no superimposition of other posterior bony structures. The advantage of this projection is that if there is a fluid level within the maxillary sinus, that it should be visible. Certainly, because we're using a tube angulation, we will not be able to see that fluid level as a horizontal structure, but rather we should be able to see it in some extent. Whereas in the previous projection, it would have been superimposed over those posterior fine base of skull structures, with the bottom third being filled up by those ridges. So the Waters projection can be performed with a series of different angulations, and depending upon your placement center and the professional environment in which you find yourself working, these chordad angulations may vary. You'll notice that as we increase that chordad angulation, that the inferior orbital margin will no longer be a horizontal structure, but that we will see more and more of the maxillary antrum. It's important to recognize that as we center with greater and greater degrees of chordad angulation, it may be necessary for us to center rather than the Nasal on more inferior structures so as to be able to include the entirety of the cranial vault. So instead of always centering through the Nasal, it may be necessary to center further down. As you can see, when we are using the more extreme amounts of tube angulation around the nature of 40 degrees or even more, that the centering point is almost through the mental symphysis, and obviously the image receptor has been displaced to compensate for that. So these three projections show the water's projection with different angles. At the beginning, it's a relatively PA position. In the middle, a water's projection with around about a 20-degree angulation, and the image on the far right-hand side of the screen shows a much higher, perhaps a 30 or 40-degree angulation. So as you increase your angulation, the maxillary antrum becomes clearer, but the inferior orbital margin becomes a thicker structure and less able to be seen. When a patient receives an injury to the facial bones, it is very common for the inferior orbital margin to be fractured, and that can then subsequently cause a filling of the maxillary sinus with blood and edematous fluid. So being able to see the inferior orbital margin and the maxillary sinus is an important part of your facial bones radiography. The water's projection is also quite good for showing the eyes and the orbits. When we perform a water's projection for the eyes or the orbits, the nature of the tube angulation and beam means that we can see the eyes quite well, particularly, as I say, that inferior orbital margin. You can see in front of you there some of the anatomy of the facial bones, just to be able to maintain your knowledge base of facial bones radiography. Let's now move on to the lateral facial bones projection. This is normally undertaken as a projection so as to be able to have multiple views at 90 degrees. It's not a particularly useful projection in many ways because it will have superimposition of the bilateral structures of the facial bones. The lateral facial bones projection is very similar to the lateral sinus projection, which we talked about in the previous video, and all of those same principles apply. Move the patient into about a 45-degree obliquity and towards the board, and then get them to rotate their head so that they're in a true lateral position. You should be squatting down in front of the patient, with the intention being to ensure that their interpupillary line is a horizontal structure. That is, that they are in a true lateral position and their head is not tilted, nor should it be too far tilted down or up. The central ray for a lateral facial bones projection is 2.5 centimeters or 1 inch posterior to the outer canthus of the eye, and the collimation should be approximately to the border of a 24 by 30, and then bring that collimation in until it just touches the soft tissues of the nose anteriorly and about the middle of the ear posteriorly, because there are no facial bone structures anterior or posterior to that. This is a lateral facial bones projection. You can see that on this patient, and this young lady has a fairly slim build, but you can see that she is on a nearly 45-degree rotation of her thorax, and only the superior part of her neck and head is in the true lateral position. Notice on this particular projection that the patient's gaze is upward. That will be something which we'll consider in a short period of time. So a lateral facial bones projection should have radiographic superimposition of bilateral structures. The closer these bilateral structures are to the middle of the image, the more likely they are to be superimposed, and those on the periphery of the image less so. We should see the entirety of the facial bones, and ideally you'll see the soft tissue contour of the patient's nose anteriorly. You can probably just see the outline of the lips there, and about mid-ear is as far as you want to see posteriorly. If the patient has any fluid levels within their maxillary sinuses, they should be shown as a horizontal structure, that is, you're shooting across that fluid level. And now some supplementary and extra projections of the facial bones. The Waters projection is a very good projection for the eyes. When we have a look at the eyes, much of the time when a patient presents for an orbits or eye x-ray, the clinical history is a queried or known foreign body within the eyes. This might be as part of a pre-MRI screening check where a patient may have a previous history where they have been working with metal and may have some ferrous metal within their globes. We have many industry workers who will have MRI scans, and so obviously that's a preventative test that we can do. Or we might have a patient presenting in the acute environment who has a queried foreign body of the eyes. In either circumstance, it's very common to perform a Waters projection for the eyes, or indeed to perform 3 Waters projections of the eyes. The positioning is very similar to our previous Waters projections, except for the fact that the central ray passes through the level of the eyes and that the collimation is going to include the entirety of those orbits. The patient instruction is the critical part of this projection. You're going to perform the projection 3 times, and the patient will be instructed to change the way that their eyes are looking. This is referred to as the patient's gaze. You are going to tell the patient to look upwards and to fix their gaze on a particular point and to keep their eyes very still, and you'll perform 1 projection like that. The second projection with their eyes looking straight ahead. The third projection with the eyes downcast. A downward gaze, once again, fixed on a point in space. These projections need to be very clearly labelled so that the radiologist or referring physician is aware of which projection being which. You need to ensure patient compliance to make sure that the eyes do stay in a fixed position. And one of the things which I would advocate doing is to have your marker placement correlate to the gaze. That is to say that when you have the upward gaze, put your marker at the top of the image. At the neutral or straight ahead gaze, at the middle of the image, and on a downward gaze, place your marker at the bottom of the image. That way there can be no doubt or ambiguity about which projection has been done. The position of a known or queried foreign body within the globe will vary depending upon the depth of that foreign body and the extent to which the patient has been able to change their gaze. So it does require a fair amount of patient compliance, and as such I encourage you to coach and communicate with the patient well. So a Waters projection with orbital foreign bodies, the actual bony structures themselves will appear quite similar. However, your marker placement will be useful in being able to identify which projection is which. The submentovertical or SMV projection is probably one of, if not the most challenging projections of the skull. The purpose of the submentovertical projection is to be able to create another image at 90 degrees to your PA and lateral projections by having the projection pass from the inferior part of the patient's cranium to the top. This requires a very great degree of patient compliance. The submentovertical projection can be performed with the patient starting in a seated to supine position, or it can be in an erect posture. I'll start with the supine positioning and then work on to the erect posture. When a patient presents for an SMV projection, essentially you're going to have the central ray passing through the patient's orbitomeatal line at 90 degrees. The patient's orbitomeatal line ideally would be a horizontal structure, And that would be achieved by having the vertex or the top of the patient's head in contact with the image receptor. Now, on a supine patient, as you can imagine, that requires a very great hyperextension of the patient's neck, and it requires for the patient to have their head essentially upside down. The extent to which the patient is able to hyperextend their neck will define the tube angulation. So one of the important parts of this projection is for you to have a look from the side of the patient, find the orbitomeatal line that the patient can maintain, and then to change your tube angulation to cut through that orbitomeatal line perpendicularly. We start off with the patient in a seated position. They are shaped like a capital L, if you like. You're then going to place 3 of the fluffiest pillows you can find in the department against the patient's lower back. You're going to then encourage the patient to hyperextend and bend over those pillows, and then to tilt their chin further back so that their head is essentially completely upside down. The vertex of the head will be in contact with the image receptor or the supine buccal. Then you will place your image receptor such that the primary beam will be cutting right into the middle of that image receptor, and make sure your angulation corresponds to that perpendicularity to the orbitomeatal line. You'll collimate to the borders of the image receptor on a 24 by 30 portrait image receptor. Now the instructions here say stay still, but realistically this is one of those projections where you absolutely must coach your patient, encourage them to be compliant and to keep up communication to let them know that you will be getting them to be seated back again to get normal blood pressure flow as soon as you possibly can. Now this projection can also be performed with the patient seated, and some patients find this more comfortable, some less so. I tend to do mine supine just because I find that patients move around a little bit less. However, if you wanted to do it in an erect position, start off with the patient in a chair, but not a chair with a very high back on it, because you need to have a certain amount of extension of the patient's lumbar spine. Then move that chair approximately 30 centimeters away from the erect buccal. Then have the patient seated in an AP position, and then with you holding on to the patient's shoulders, ask them to hyperextend their neck, tilting it all the way back until the vertex of their head is in touch with that image receptor against that erect buccal. Encourage the patient to keep that extension, that hyperextension of their neck, and from there utilize your tube angulation once again perpendicular to the orbitomeatal line. Talk to your patient and find out what position is going to be most possible for them. You can see on the right hand side a patient who's having an SMV projection in an erect posture, and you can see the extent of hyperextension. Notice how the patient's chair has been moved away from the erect buccal. The patient on the left hand side of screen is about the only SMV projection that can be found, but I don't actually advocate using this position, basically because it's a lot of mucking around with that image receptor there, when we probably could get the patient through a greater degree of hyperextension by putting some pillows underneath their back. So that photograph on the left, not so useful. When you perform an SMV projection well, you should get something which looks like this. The mandibular symphysis should be just jutting off the main part of the skull a little bit. You should have the mandibular condyles in front of the petrous pyramids, but you know you've performed this projection well in terms of rotation or tilt when you can see the patient's zygomatic arches standing proud of or not immediately superimposed over the rest of the cranial vault. Notice how this patient's zygomatic arches are projected really quite a fair way off the skull. As you can imagine, if the patient had a fracture of the zygomatic bone, that this would be a very useful projection for being able to show the displacement of that zygomatic arch. Depending upon the amount of tube angulation, you might also get a submentovertical shot of the patient's nasal bone. Now, I mentioned in the previous projection that the SMV projection is quite good for the zygoma. However, there are times when that patient's not able to undertake that projection, in which case, if you wanted to investigate the zygoma, one alternate is to use the Towne's projection, which we covered all the way back in the first cranial vault video. If you were to use the Towne's projection, which has that 25-degree chordate angulation, and to center through the middle of the zygoma, you should end up with a projection, much like you can see diagrammatically here, which cuts through the zygoma at close to 90 degrees. It's not as good as an SMV, but it's quite close. This projection, when performed like this, should come up with something which looks like this. You can see how the patient's zygomatic arch has been projected out from the rest of the face. It's not as good as an SMV, but it does show any degree of displacement of the zygomatic arch. Because this Towne's projection has a very, very tight collimation down to a slit-like exposure area, you'll occasionally hear this referred to as a slit Towne's projection. The Waters projection also has some utility in having a look at the patient's nasal bones. If you perform a Waters projection and for a patient who has a nasal bones fracture, you might want to take an extra Waters view, very, very tightly collimated over the patient's nasation to get good detail of that nasal bone. It's quite good for a patient who has a queried deviation of the nasal septum. However, the most useful projection of the nasal bones is the lateral projection. When a nasal bones projection is performed with the patient in a true lateral cranial vault position and you are centered over the middle of the nose, then you can actually get some very, very good detail of the fine structures of that nasal bone. You'll notice that unlike all of the previous projections, we've mentioned that there is no grid for this particular one. You only need to use a finger exposure, so we're talking in the range of 50 kVp, somewhere around about 2 or 3 MAS is an ideal exposure to get a true lateral projection of the patient's nasal bones. Nasal bone projection, you can see on the right hand side of screen that lateral projection. If the patient did have a fracture of those nasal bones, we'd see it displaced there quite nicely. On the left hand side of screen we have a Waters projection, and that blue box indicates the approximate area that you should be utilizing for a nasal bones Waters projection. And that covers our positioning of the facial bones. If you have any questions, please jump onto discussion board.